Welcome to First Aid AMC Clinical free 2-week sessions again. So today we are going to do a theory session, right? So our classes are divided in this way so that sometimes we will be doing theory-based classes, just like how we are doing today. You already had a theory class, which was psychiatry history class, right? And we did a role play on that. After that, you had a session with Dr. Cynthia, and that was just based on a random role play session on recent important cases. And today we'll be doing cardiology. So for cardiology, we take 2 classes, and after that we do a cardiology role play as well. All right, so let's start our tonight's session. If you guys have any questions in between, feel free to write it in the chat box. Okay, so cardiology is a part of your medicine topic. From medicine, a lot of questions come in the exam, and most of the medicine related questions we'll be doing as a cluster-wise approach. If you heard about First Aid AMC, you must know our cluster-wise approach, and this is one of the best approach that anyone can come up with. So what we normally do with this cluster approach is that we make a history format for, let's say, syncope cluster is our first cluster today. So we will make a history format for any patients coming to you with syncope. We'll be doing a format for physical examination, and you can use that format for any of the questions that come with syncope. So in that way, what happens that if you need to, let's say, there are 5 or 6 questions related to syncope cluster, and if you need to memorize all those 7 cases one by one, it becomes very difficult, because in that way you have to take more time, you have to memorize a lot of things. But if you have a history and physical examination format in your head, then you can use this format to cover the 7 cases. So that becomes very easy for you to remember in the exam also. And remember one thing, that you will not just use this kind of cluster approach in exam, you'll be using this throughout your life. And our students, like there was a student who just sent me a message maybe a few weeks ago saying that, "Doc, I have passed my clinical exam. I've started working in one of the ED in Australia, and still I'm using your cluster-wise approach, and my seniors are very happy with my approach." So see that these approaches are not just for passing the exam, this is for your lifetime. And try to gather this information, try to understand how to make the preparation smarter and shorter rather than doing everything. I've seen candidates who uses 5 or 6 notes and then end up not retaining any important information. So that's not what we ask you to do. In First Aid AMC, you get everything that you already need for your exam. You don't need any other notes. You don't need anything. So if you can finish what we are giving to you, that will be more than enough. Okay. So let's start the syncope cluster today. So syncope means loss. So what could be the cause of syncope? So first of all, in exam, differential diagnosis is a vital part to understand, and you have to memorize it. There is no other way. You have to know the differential diagnosis of a particular topic. So what are the differential diagnoses of a patient presenting with syncope? So there could be CVS related, it could be CNS related, or it could be miscellaneous. So CVS related syncope could be any arrhythmia. Aortic stenosis can be a cause. HOCM, which is hypertrophic obstructive cardiomyopathy, that can be a cause. Sometimes myocardial infarction can present with dizziness or even syncope. And there is a condition called prolonged QT syndrome that can also cause syncope. Okay. For your exam, arrhythmia is always important. Aortic stenosis is also important for exam. I haven't seen HOCM anytime in the exam. MI comes under chest pain cluster. Prolonged QT syndrome, also important for exam. Then there are CNS causes, so it could be transient ischemic attack or stroke, could be head injury, infection, so infection related to the brain, means meningitis or encephalitis, and then epilepsy. Others could be vasovagal syncope, so that's an important case for exam. Could be postural hypertension causing syncopal attack, also very important for exam. Could be hypoglycemia. Anemia can present with syncope. Sometimes some medication, especially if a patient is on multiple hypovolemic drugs like antihypertensive, that can cause it. Sometimes it could be just stress or psychogenic, which is not very common, but still we should rule that out. Okay, so these are the differential diagnoses of any patient presenting to you with a syncopal attack. Now, today you will learn about the approach of a medicine case, and you can use this kind of approach for any medicine. Excuse me, my voice might be a little bit croaky today. It's just I'm having a little bit of flu, so excuse me for that. So first of all, when you start taking the history of any medicine cases, your approach is very important. And how you can start a patient who is presenting to you with a syncope depends on the mode of the exam. Is it a syncope cluster coming in online exam, or is it coming in face-to-face? So that's important because there is difference in approach of the mode of exam. So because most of you will go for online exam, let's start with the online format and how we are going to start this kind of case. Now remember one thing, in online exam, as I have mentioned in your first class, that there will be few people in your video. One will be the invigilator, then there will be another one who is the role player, and then there will be examiner. You can't talk to the examiner in online exam, and you can't also see the examiner, but examiner usually will be there in your exam. Okay, so who will talk to you? Obviously the role player will talk to you, and invigilator sometimes talk to you. It just when they help you to give the timer, and sometimes they give prompt in your exam that your time is up or something like that, and also to rotate you around the case. So you can't ask any questions to the invigilator related to a particular case. Okay, so when we start a online case like this, so we will say something in this way. Let's say patient name is John. So you will say, "Hi John, this is," or you can say, "Hi John, I am Arshan. I'm one of the doctor in this clinic. It is very nice to meet you. I understand from the notes that you had a recent loss of consciousness." Patient will say, "Yes, doc." You can say, "I'm very sorry to know about that, John. How are you feeling right now?" Patient will say, "Well, doc, it happened yesterday, but I'm doing good today." Then you say, "Well, that's very good to know. So, John, because you had a loss of consciousness, before I ask you any more history, I would like to make sure that you are vitally stable. So I will check your blood pressure, your pulse, your oxygen, and also your respiratory rate, just to make sure everything is all good. Is that okay with you?" "Yes, doctor." So patient will say, "Yes, doctor." Now, the problem is you can't actually do anything in here. So you just say that, yes, you are going to check it, and that will cover the hemodynamic stability part. What we do in face-to-face exam is that once we ask the patient, "How are you feeling today?" Patient will say, "Doc, I'm feeling okay, but I had a loss of consciousness yesterday." You will say, "I'm sorry to hear that, John. John, because you had a loss of consciousness, I need to make sure you are vitally stable from my examiner. So please excuse me for a moment. I will talk to my examiner and come back to you." So then you will rotate towards the examiner. That's face to face. And you will ask the examiner, "I would like to know if my patient vitally stable or further history." Examiner can say, "Yes, your patient is fine, you can move on." Examiner can say, "Stick to your task," meaning that they don't want to give you the result at the moment. Or they can ask you that, "What do you want to know?" If examiner asks, what do you want to know? Then you just ask, doctor, I would like to know the blood pressure, including any postural drop, pulse, rate and rhythm. So you can only ask two at a time. After they have given you blood pressure and pulse, then you can ask the other three, which is respiratory rate, temperature, and oxygen saturation. So these are the 5 components of vitals: blood pressure, pulse, oxygen saturation, respiratory rate, and temperature. Okay? Are you getting the point that how we are starting in face-to-face and online? So in online, there is no one who can give you the result. You are just saying that you are going to do that, and then you will move to the next task. Okay, so let's stick to online version because that's what you are doing mostly. So you will say that, hi John, this is Arshan. I'm one of the doctor in this clinic. It's very nice to meet you. I understand from the note that you had a loss of consciousness yesterday. I'm very sorry to know that. How are you doing now? Are you feeling comfortable? Yes, doc, I'm okay. Well, John, because you had a loss of consciousness, I just need to make sure you are vitally stable. So I will check your blood pressure, your pulse, your oxygen, respiratory rate, and just to be clear that you are fine with further questioning. Is that okay with you? Yes, doctor. Then you will say, well, John, now would you please tell me a little bit more about what exactly happened yesterday? So what we have done, we just bypassed that point where in face-to-face, we could ask that thing from the examiner. Because examiner doesn't talk to us in online exam, so we will not do that. We will just go to the next part. Okay? So you will say in here, so this is called history of presenting complaint. In the course, multiple times you will come across this thing called HOPC. So HOPC is history of presenting complaint. History of presenting complaint means that what is the main presentation for this patient? So in this case, syncope is the main presentation. So you will be asking detailed questions about syncope in here. And we divide the syncope question as pre-syncope. That means what happened before you lost consciousness. Syncope, that means what happened during your loss of consciousness. And what happened after you regain consciousness, which is post-syncope. So this will be your initial history of presenting complaint, and that will be detailed questionnaires. So first you are asking that, so always in the exam, start with an open-ended question, always. That's must, because if you don't ask open-ended question, then role player cannot give you the information they were supposed to give you. So always ask, can you please tell me what exactly happened yesterday? So patient will say, well, doc, I was just running or jogging at the park and suddenly I felt dizzy and then I think I lost my consciousness. And one of the other guy found me in the road. So something they will give you, and then whatever patient did not give you, you will ask from the patient. Okay. So first open-ended question, and then you say, if patient doesn't give you enough information, then you will have to ask that, what exactly were you doing at that time? Did it happen for the first time? Now, if patient say, no, doc, it's not for the first time, it happened also few other times. In that case, you will have to ask the detail of the previous episodes also. So you'll need to say, how many episodes so far? When was the first time it happened? Can you explain those events as well, that what were you doing and how that happened? So it gives you a perspective that what brings it on and what are the times when patient gets this syncopal attack. So anytime if patient get these previous episodes, you need to ask the detail about it as well. After that, now you have to ask any prodromal symptoms before the syncope. So did you fall suddenly or did you feel lightheadedness before you fall? Now that's very important. Cardiac syncope happens suddenly. Patient usually doesn't get any prodromal symptoms. That means they don't know that when they are going to fall. Whereas if it was a vasovagal syncope, patient usually will get a prodromal symptom. That means they will know that they are going to fall. All right. So ask the patient, did you fall suddenly or did you feel any lightheadedness or dizziness before you fall? And then just quickly ask about any CNS, excuse me, any CNS related symptoms. So any headache, any blurring of vision, any weakness, any part of the body. So that will cover the CNS causes. Then come to the syncope question. So first of all, obviously patient lost consciousness and he would not know what happened during this time. So that's why we asked, was there any witness? If patients say yes, you can also say, well, if you give me the consent, then I would like to discuss what happened during your loss of consciousness. Obviously, you can't do that because there is no one else in the exam. So in that case, you can also say, well, did the other guy tell you what happened during you lost consciousness? Then patient can say, yes, I know. So you can say that, well, did you lose your consciousness fully? Yes. How long did you lose your consciousness? Did you get any jerky movement in your body? That's for epilepsy. Did you wet yourself or pass a stool? Same for epilepsy. Did you bite your tongue? And did you injure your head by any chance? All right. So these are the questions that we will be asking for what happened when you lose your consciousness. And then go to the post syncope question. So after you gained your consciousness, were you able to stand by yourself or someone helped you? Why we ask it? If a patient with cardiogenic syncope, they usually will get the syncope suddenly and they will also gain the consciousness suddenly without any confusion afterwards. But if it is epilepsy, patient usually gets 30 to 40 minutes of post-ictal confusion after gaining the consciousness. So that's why we are asking that were you able to stand by yourself or someone had to help you? Did you feel confused and drowsy afterwards? If yes, then how long were you confused? Any weakness or any problem with your vision or speech? That also cover your CNS related cause, which is stroke or TIA. So for stroke TIA, you already asked question, which is headache, blurry vision, weakness anywhere. You asked about vision or speech problem as well. All right. So pre-syncope questions, syncope questions, and then post-syncope questions. These will be your detailed questionnaires. After that, you will move on to differential diagnosis question. So far clear, everyone? Now there is a question. So Dr. Mariam, in online exam, do we wait for the vitals to be shown? No, they usually don't. Very unlikely that in online exam they will show you the vitals. So you don't need to wait for it. You just proceed. Perfect. So once your HOPC is done, you move on to the differential diagnosis question. So for differential diagnosis, you have CVS, CNS. So for CVS, ask any chest pain, any shortness of breath, any racing of your heart. So we haven't asked this question yet. So we need to just rule out myocardial infarction. So ask about any chest pain, any difficulty breathing, any racing of your heart. You can also ask any nausea or any sweating because nausea, sweating is also a part of MI. Then ask CNS. For CNS, any head injury. For infection, you are asking any fever, rash, or neck stiffness. That's meningitis or encephalitis. That's one of your DD as well. Stroke, TIA, epilepsy, you have already asked in the syncope questions. So after CVS, CNS, then you have got others. So in others, you have got hypoglycemia. So by any chance, you skipped your meal today. Sometimes patient can skip their meal and then do a vigorous activity or exercise and can end up having a low glucose. So ask that did you skip your meal today by any chance? Now for vasovagal syncope, there is not any specific questions. So how you normally know that it is vasovagal syncope? most of the time the question give you some clue, like patient was running a marathon and it was a very hot sunny day, okay, or patient was standing for a long time. So something exertional can bring on this vasovagal syncope. And patient with vasovagal syncope, they get a prodromal symptom. That means they know that they are going to have a fall, and then they lose their consciousness, and then they gradually regain their consciousness. So we'll do a vasovagal syncope case today, so you will understand it. But for vasovagal syncope, if you want to ask question, you can ask that, well, was it a hot sunny day? Or you can also ask that, did you overexert yourself yesterday? Okay. For postural hypotension, do you feel dizzy or lightheaded when you change your position, especially when you get up from the bed in the morning? So patient with postural hypotension, when they change their position, they feel dizzy. And that mainly happens in the early morning when they wake up from the bed. So ask this question, do you feel dizzy or lightheaded when you get up from the bed in the morning? For anemia, you can just ask, do you feel tired and fatigued these days? Now, you can see now that we are just asking one question for each of the differential diagnoses, because we don't have that much time that we will ask each and everything in the exam. So just one question is enough for each differential. Now, if any of the differential diagnosis, if you get positive finding, then you ask more detail about that. Like if you would get postural hypotension positive in this patient, then you would ask a lot of other questions in here. So that will be discussed in the cases. Okay. Then for stress, you can just ask about, so first give some confidentiality because you are asking some psychiatric question. So say that, John, I'm going to ask you some personal questions about your home and work situation. Please be aware that these are confidential between you and me. So John, are you under any kind of stress at your home or at your work? Patient will say no. And then finish with past medical history, SADMA, and family history. So in the past medical history, you can ask any other medical condition, especially any diabetes, any high blood pressure or heart disease. And for SADMA, just ask, do you smoke or drink alcohol? Are you on any medication? Any family history of sudden death, especially related to heart, any family history of heart condition. Now, if you see the format has a specific pattern. So you can see first is introduction. If needed, so all acute presentation, we will be making sure if the patient is hemodynamically stable. Then HOPC, so detailed about that. Then the differential diagnosis question. And lastly, finish with past medical history, SADMA, and then family history. So these will be the format of most of our medicine cluster. Okay. So if we give you a summary of what we have discussed so far, so you can see first introduction, making sure patient is vitally stable. Then the HOPC, we asked about pre-syncope, syncope, and post-syncope questions. And then we asked the differential, severe CNS, hypoglycemia, vasovagal, postural hypertension, anemia, stress, and lastly finish with past medical history, family history, and SADMA. All right. So that's your history. Any question with the history? That's right, Dr. Shoma. So in online exam, most of the time, if it is an acute presentation, vitals will be given in the STEM. Perfect. So let's move on to physical examination. Now, this is a confusing part because you'll always feel confused that what kind of physical examination comes in the exam. Now, going into a little bit of understanding about the clinical exam. In clinical exam, you have two different kind of cases. One case is the common ones, which is like they ask you to do history from the patient, and then They can either, in online exam, they give you a card, so physical examination card will be given. Sometimes they can ask you that explain the physical examination to the examiner or to the patient, and then a card will appear on the screen. Okay, so these are the two ways. And then after history physical examination, they can ask you to give the diagnosis, and sometimes differential diagnosis, and then sometimes management. Not all of it comes in one case. Sometimes physical examination is not there at all. Sometimes management is not there. So this is a usual format of task. There is another format in which you only do physical examination. So they say that a patient coming to you with right-sided knee pain, you have to explain to the medical student how you are going to do knee examination on this patient. So that's explanation of physical examination. So we are discussing the online format. So this is a solely physical examination case. And sometimes after physical examination explanation, they can give you the finding on the screen. And based on the finding, you have to give the diagnosis and differential diagnosis to the medical student or to the patient. Okay? So this physical examination and this physical examination is different. In here, you have to use your 8 minutes to do the full task. But in here, you have just a very small time for the physical examination. Okay? Is this is making sense for everyone? Yeah, very good. So now there is another thing. In case of face-to-face, that's called physical examination from examiner. I know that a lot of you will not go for face-to-face exam, but a lot of you never know that what will happen in AMC. Sometimes they include things, so we never know. So we would discuss how face-to-face works anyway. So in case it get happened again in AMC, you should know about it. So in face-to-face, what happens is that they after history, the next task is usually asking physical examination finding from examiner. Okay, so how to ask physical examination finding from examiner? That's one part to learn. And then how you're going to read the physical examination card, and if there is any explanation of physical examination, how to do that, that's what I'm going to discuss now. So let's say we are discussing the online format first. The easiest format is after your history is done, the next task can be a physical examination card will be given on the screen. Okay, and you just need to read that by yourself, and then go to the next task, which can be diagnosis and DD. So in the physical examination card, they will give you all the finding for this particular case. And you just read it by yourself. You don't need to read it loudly to the patient. There is no need. And a lot of candidate does it, but AMC doesn't like it. No one likes it. So please don't read it loudly. Just read it by yourself, come to a diagnosis based on that. So that's the easiest way. The other one can be, it's not very commonly asked, but it can. So sometimes what can happen that they can say, explain what physical examination you will do to your examiner. So you will explain it to the examiner, or sometimes they can say, explain what physical examination you are going to do to the patient. So depending on what they ask, you will do that accordingly. So always remember, in case of AMC clinical exam, when you talk to a patient, you can't use medical jargon. Now, and if you use a medical jargon, you have to explain it. But when you talk to a medical student or to an examiner, then that's fine. You can use medical jargon at that time. So if you say to a patient that how is your micturition? Or if you say that your let's say that your pancreas is very bad. Your uh, you have a gastric ulcer. If you say gastric ulcer, you have to explain what is gastric ulcer. So everything is like that. Towards a patient, when you are talking, you have to make sure that you use as less medical jargon as possible. And if you need to use it, explain it straight away. So let's say that we are discussing the second part of it. So explain what physical examination you are going to do towards your examiner, and then examiner will give you the finding on the screen. So in that case, you will just say all of this at a time. So you will say, dear examiner, I'm going to do physical examination on my patient who presented with a sudden onset of syncopal attack yesterday. First, I would check his general appearance to make sure he looks comfortable or in distress. I would check for, now this is pickled. So what this pickled means, P for pallor, I for icterus, which is jaundice, C for cyanosis, K for clubbing, L for lymphadenopathy, E for edema, and D for dehydration. So pickled is a very important part of general examination, but not everything we have to ask or not everything we have to look for. It's a relevant one. For this particular case, relevant is checking for pallor because anemia is a cause of syncope. And if you want, you can check for lymphadenopathy because if patient having any kind of cancer causing the syncope, we don't know, but you can always ask for lymphadenopathy, edema, and dehydration everywhere. So you will say that first I would start with general appearance to look if my patient looks comfortable or in distress. Then I would check for any pallor, any cyanosis, any edema or dehydration. I would like to check the vitals, including blood pressure in both sitting and standing position, pulse with rate and rhythm, saturation, temperature, and respiratory rate. Then I would start with the neck examination, looking for any raised JVP or if the carotid bruit is present. So obviously, in a syncopal patient, carotid bruit is important. Can anyone say why we are looking for a carotid bruit in this patient? Very good, Dr. Jamshena. TIA. To rule out TIA, carotid, if a patient has got carotid artery stenosis, then carotid bruit will be important. Okay, so it's basically for checking out any possibility of a transient ischemic attack causing this syncope. For JVP, it's not super important in this case, but you can ask it for any cardiac examination. So you will start with the neck for any raised JVP or any carotid bruit, and then you'll do CVS exam. So then you will say, then I would do a full cardiovascular examination, starting with inspection of the precordium, looking for any visible cardiac impulse. Then I would do a palpation. I would first check the apex bit if it is in normal position. I would check for any palpable thrill, any parasternal heave or palpable P2. And then I would do auscultation. I would check the S1 and S2 heart sound and looking for any other added sound, especially any S3 or S1 and any other murmur. And then I would do a full central nervous system examination, both upper limb and lower limb, including the cranial nerves. And then I would finish with all other systemic examination, including you have left with respiratory system and abdominal examination. I would check for any office test. So I would check for blood sugar level to rule out any possibility of hypoglycemia, urine dipstick for any likelihood of an infection, which is unlikely in this case, and most importantly, a ECG to rule out any arrhythmia. Okay, so that will be your physical examination explanation to the examiner. So in this case, you will be just saying everything at a time, and after that, a finding or a PFE card will appear on the screen. Now, this is not very commonly done in the exam. Most of the time, a physical examination card is given in your exam. Okay? Is it making sense that how to do this? Okay. Now, let's talk about what will happen if this is a face-to-face case. In face-to-face, you have to ask each and everything one by one, and examiner will give you the finding. So you will say that after your history in face-to-face, you will say, dear examiner, I would like to do physical examination of this patient. First, on general appearance, does the patient looks comfortable or in distress? Then examiner will say, comfortable. Is there any pallor, icterus, any sign of lymphadenopathy or dehydration? Examiner say no. I would like to know about the vitals, blood pressure, pulse rate. Examiner will give you the vitals. So blood pressure is 120 by 80, pulse rate is 100. Okay. And then, so this is the way of doing the physical examination from examiner in your face-to-face exam. So one by one, you will be asking each and everything that we have discussed, and then examiner will give you the finding. Examiner will only give you the finding, only they will give you the finding that you are asking, not anything extra. If you miss something, they will not give it to you. Okay? So in that way, online examination is easy because you're not killing the time by asking all of this physical examination from examiner, and chances that you will miss something is also less. Okay? So that's your physical exam. Now we will use this physical exam format for any cardiac case. This is the only physical examination format that you will need for history related cases. Okay. So remember general appearance, pickled, vitals, neck, CVS, inspection, palpation, auscultation, then CNS followed by other system and office test. Now you might be thinking, what is this office test? So office test is something which can be done as a bedside test. And in AMC exam, there are only a few number of office tests that you can ask for. So one of these are this urine dipstick, blood sugar, ECG, and then there are few. So you can ask for a urine pregnancy test when it is relevant. You can ask for, sometimes even you can say ABG or VVG if you need that. And you can also you can ask for any spirometry finding, especially if it was a case of COPD or asthma. Okay, so it's a very small number of office tests that can be asked in the exam. You can say that, can I ask a X-ray? No, X-ray is not an office test. X-ray is an investigation that you will need to organize. All right, so only this, urine dipstick, BSL, ECG, and those two. So once your physical examination is done, so you know now that this is the format for history and physical examination in terms of syncope cluster. Once we know this format, we can easily finish the cases. So we will start with the first case, which is aortic stenosis. So if office test not available on physical examination card, then can we mention it? If something is not available, that will not be given to you. So no need to ask it. So your first question, so this is your aortic stenosis, which is a syncope cluster case. You are a GP and your next patient is a 52-year-old male who is consulting about recent loss of consciousness. So you can see that this is how a stem will look like. 52-year-old coming to you because of recent loss of consciousness. Your task is focused history. Now, in online exam, this will be a physical examination card will appear on the screen. And then they can say order necessary investigation and then give your diagnosis and management. Remember one thing, for online exam, management is more important because in face-to-face, hardly management was coming in the exam. But in online, I have seen that management is like almost every case has management. So you have to know the management a little bit more for online exam. Okay, so we already know the format of history. So what will be the positive finding in this case? So this patient will say that, doc, I was playing tennis yesterday and suddenly I started to black out. So patient was playing tennis and then had a syncope, and patient will say that patient's feeling short of breath or having an exertional dyspnea for 2 months, chest tightness and chest pain also on and off for 2 months. So this is a triad for aortic stenosis in which patient is usually elderly patient coming to you with syncope plus shortness of breath on exertion plus chest tightness or chest pain. Okay, so this is the triad of aortic stenosis, which you will find in this case when you ask one by one, when you will ask all those questions, you will get this finding. And then when you come to the physical examination card, you will find that patient having an aortic stenosis murmur. So in the physical examination, you found that patient left apical impulse is displaced, and most importantly, you will get a ejection systolic murmur in the aortic area, which will radiate to the neck or carotid. Okay, so remember that aortic stenosis murmur is the ejection systolic murmur, which you will find in the aortic area, and that usually radiates to the neck or carotid. And then you'll come to the explanation. So that's the main part of cluster. So in the cluster, you can see we are not doing any history and physical examination anymore because we have already done it. And we know how to ask history for this case. We know how to do physical examination. And if we only know the positive findings of that particular case, only thing that we will need to remember is how to manage this. Okay? So one question. So if there is any positive findings such as chest pain and shortness of breath in this case, do we need to take a history of this complaint? Yes. Not the whole chest pain question, not the whole shortness of breath question, but at least a little bit. Like if there is shortness of breath, you have to ask that, well, how long this is happening? And is there anything particularly what makes it worse? Especially, is it related to exercise or even at rest you are getting it? Do you think it's getting worse? Okay. So, and how long you can walk without getting short of breath. So there are some shortness of breath question, which we will discuss in shortness of breath cluster. But you will have to ask questions in that case. Same with the chest pain, you have to ask the duration, what brings it on, what makes it better. So, and also the characteristic of the pain. Now you will come to the explanation. So you will say that from the history and physical exam, most likely you are having a condition called aortic stenosis. Okay. Now this is how we explain a particular case. So it's always better that because you are a junior doctor in AMC clinical exam, you are not appearing that exam as a specialist. Many of you are a specialist in your country, but please don't think in that way in this exam because you are a junior doctor in their eye. And most of you will start as a junior doctor in the hospital. So what they actually want you to do is to be in that way that don't say anything that you're sure. You will always say the provisional diagnosis, which means most likely. You will not say, John, you are having a condition called aortic stenosis because you haven't done any test yet. You haven't done an echocardiogram which could confirm this. So you will always say that, John, from the history and physical exam, most likely you are having a condition called aortic stenosis. So that's a better idea to say the diagnosis rather than saying, John, from the history and examination, you are having a condition called aortic stenosis. What if when you did the echocardiogram, it doesn't show aortic stenosis? Okay, so that's why always use most likely before your diagnosis, and then say that, well, do you know about it, John? No, doc. Well, in that case, let me explain in detail. If you don't understand me, please feel free to ask. So, John, that you know that we have we have our heart on the left side of the chest, and the heart has got 4 chambers. Each of the chambers has a door-like structure called valve. In your case, the valve that controls the flow of blood from the heart to the aorta is blocked or is narrowed. So again, we have got our heart on the left side of the chest. Heart has got 4 chambers. Each of these chambers has a door-like structure called valve. See that I am using the medical jargon, but I have explained it. That's how you do. In your case, the valve that controls the flow of blood from your heart towards the aorta, and this aorta is the biggest blood pipes which supplies blood to whole body. In your case, that valve is most likely narrowed. Because of that, the blood supply to the brain is also reduced, and that's the reason why you got loss of consciousness, because when you exercise, the demand of oxygen gets higher. On the top of that, your brain doesn't get blood, so you lost your consciousness. And also, you started to get more short of breath, and also you get chest pain because your heart is not able to pump enough blood to your whole body. So that's how you can explain. Now, it is always important that when you explain a particular condition, you have to explain why this patient is feeling short of breath, why this patient getting chest tightness, why the patient got loss of consciousness. There must be some reason behind it. If you can explain it a very simple way to the patient, they will be very happy with your explanation because they want to know. They don't care about the aortic stenosis, like how it gets narrowed and all the pathophysiologies. They want to know why I'm getting loss of consciousness, why I can't play tennis with my friend. That's what they want to know, and you have to explain that. Okay, so that's what we have written in here. So the valve that controls the flow of blood from your heart to the aorta is narrowed. That is why blood supply to the brain is being reduced, causing the loss of consciousness. And when you exercise, the demand of oxygen from the heart gets increased. But given that it is already narrowed, it cannot supply enough blood and oxygen, causing the chest pain and shortness of breath. Are you with me so far, John? So always make sure you ask the patient that, are you understanding me? Are you with me so far? That's very important. In your country, you might not even explain any of this. But in Australia, each and everything has to be explained properly, and you have to connect with your patient. Okay? Then you say, always after giving a diagnosis, try to reassure the patient. Say that, John, please don't get stressed, or John, please don't get scared. It is not an uncommon condition, and we can do a lot of things to make sure that you start to feel better. But because you had a loss of consciousness, what I would like to do is to send you to the hospital to confirm my diagnosis and to rule out other diagnoses. They're going to do several investigations, including some blood tests and some imaging. They will start with full blood count, your kidney liver function, your inflammatory marker. They might also do a ECG to check for any changes in your heart. They would do a chest X-ray, and most importantly, a cardiologist who is a specialist in this case might order an echocardiogram to confirm the narrowing of the valve. And this echocardiogram is just like an ultrasound of your heart. Your further management will be done by a cardiologist based on the finding of the echocardiogram, and echo will show if it is aortic stenosis, and if it is aortic stenosis, how bad it is. And based on your symptoms and severity of the stenosis, the further management will be discussed by your cardiologist. Many times, if it is not too bad, they can just put you on conservative management and wait and watch. But if it is severe, then sometimes they can also organize a valve replacement surgery. But I'm a junior doctor in here. I'm not going to discuss all of this to you. The specialist will come and discuss in detail. Okay. Now there are two kind of scenarios. One, that if this patient is already in hospital, then you will say that I would admit you to the hospital. I will call my senior who will come and discuss, who will come and review you. And also we will involve a cardiologist for further management. Then you would do this blood test, X-ray and echocardiogram and say that cardiologist will come and review you, and based on the finding, further management will be done. Okay, but if it is in the GP setting, so there are two settings that you need to understand. Questions can happen in both. So if the patient in GP setting, you have to send this patient to the hospital for a urgent basis. Now, this is a tricky area that sometimes if it is not too bad, you don't need to send this patient straight away to the hospital. You can actually do the echocardiogram by yourself in the GP setting. You can, after you have found the specific finding, then you can send the patient as an outpatient cardiology appointment. That can be done, but given you are still a junior doctor, for this kind of cases, better to send the patient to the hospital, and in the hospital they will manage the patient accordingly. Okay, if this is the case, so if you are referring the patient to the hospital, what will you do at the end? You will always finish with, once you are stable and discharged from the hospital, we will send a referral letter. So if it is, we are talking about the hospital setting. So in the hospital setting, you will say, once you are stable and your management is done, we will send you back to your GP, and GP will follow you up regularly. And also, please make sure you avoid any strenuous activities and try to adopt a healthy lifestyle in that case. But we will discuss all of it after we know what we are going through. And after all the management is done, we will discuss about this lifestyle a little bit more details. Okay? So in hospital setting, you don't need to do the 4R. Now, anyone knows what is 4R? So 4R is something that we use to finish a task. So 4R first is reviews. So when are you going to review the patient again? Are you going to refer the patient to someone? Always give a reading materials. And then red flags. So what are the red flags for this kind of case? Now we usually use this 4R for GP setting cases, because GP usually will either GP will review the patient or refer the patient. Obviously, they will give reading materials and they will talk about red flags. But if it is a hospital setting, you don't need to finish with 4R. You will just explain the management and then say that once you are stable and discharged from the hospital, we will send you back to your GP for regular review. Okay, do you have any questions? All right, but if this was a GP setting, you would say, I would refer you, or I'm going to send you to the hospital for further investigation. In the hospital, you will be admitted, seen by a cardiologist, and they will do further investigation, including this. Based on the severity of the condition, further management will be discussed by your heart specialist. And then once you are discharged, I'm going to review you again, and we will discuss further about a healthy lifestyle modification. I will give you some reading materials so that you can also read about this condition on the way to the hospital. Okay, clear everyone that how we are finishing the two different settings? No. So we don't need to talk about the surgical management. This is not your job, because that will be discussed by the heart specialist or cardiologist. So you don't need to discuss about how the valve replacement will going to happen. Those are not part of this task. In online exam, can we draw a picture? You can, but I would not say that, because it is very difficult to draw a picture in online exam and then show it to the other person. So better not to use any picture. If you can, you can use that. It's not contraindicated, but I would say that it's not very convenient. Do we have to give reading material while urgently referring the patient to hospital? Not all the time. This one is not super urgent. You can still give some reading materials. Okay. Most of the time, if you're sending the patient to hospital, reading materials is not must to do. But if you're sending the patient to the home and then you might review the patient in a week time, then normally we give the reading materials. If the task is management only, still we don't need to discuss the treatment. They would not give this kind of question in your exam because that's for a specialist exam, not for a junior exam. Okay, so management or treatment of aortic stenosis should never come in AMC clinical. So if that comes, yes, we have to discuss, but that's not usually the case. In online exam, can we read out the PE relevant findings shown to the patient? Now, if you do that, that would not be wrong. So many times we have seen that candidates do that. So they say that, well, John, thank you so much for all the information that you have given to me. We have done your physical examination and we have found a specific sound in your heart, which we call murmur. And based on that finding, I think that most likely you are having a condition called aortic stenosis. So if you do in that way, it's not wrong. But it's not needed. And in online exam, can we read out the P findings shown to the patient? No. I would not ask you to do that because most of the time, even we have seen in the questions, it is written that you do not need to read it loud to the patient. So that physical examination card is mainly for you to read. It's not for the patient. Now you can see that they, if in AMC clinical, there is a annotation. If you can see the annotation or the marker, then you can also just draw like how I am doing. Okay, so if there is a whiteboard, if there is at least a annotation or any option of using the marker, yes, you can do it. There is no problem with that. Yeah, that's right, Dr. Ethan. If you are a doctor from hospital, you don't need to review. Sometimes we do review, but it depends. But most of the time, the hospital doctor will send the patient back to GP. In very serious cases, hospital might ask the patient to come to the outpatient department. Okay? All right. Let's take a 5-minute break and then we can start the other cases. All right? So let's take a 5-minute break now and try to remember what we have discussed and try to retain as much information as possible. If DD is not a task, can we have discussed that during management? Ideally, we say that if you have time, it is better to say the differential diagnosis in the exam. Okay, throughout the course, we will show you more and more questions. Not everything I will discuss in the same question, but it is a good idea to add the differential diagnosis if you have some time. Like what we normally do in these cases. So once you have explained what is aortic stenosis, then at this time you can say some differential diagnosis. So you can say that, well, it could be due to other causes as well. So it could be a heart attack, but you don't have a chest pain, and the ECG finding doesn't go with that. You can say it could be It could be heart rhythm disturbance, but you don't have any palpitation, so it is unlikely. It could be any kind of nervous related problem, but you don't have any weakness, no vision or speech problem, so it is unlikely to be a stroke or mini stroke. So it is not a bad idea to say the some of the differential diagnosis in this case if you have some time. Okay? And then you can say that, well, I would like to refer you and all of the same things. All right, let's take a 5-minute break, guys, and then we will come back and discuss some of the other cases. Thank you. All right, guys, let's start again. So we are going to start with prolonged QT syndrome now. So far we have done aortic stenosis. Now moving on to prolonged QT syndrome. So a 19-year-old girl comes to the emergency department because she fell unconscious 2 days ago. And she was climbing up a mountain at that time. So you can see it's a 19-year-old. Usually prolonged QT syndrome patients usually are like teenage like this or very young adult patients. They're coming to you with syncopal attack, and most of the time there will be some exertional activities related to that. So history, physical exam, so all of these are same task. Your positive finding in this case is that patient was climbing up and then suddenly lost consciousness. This is the third time that happened and doing different things each time. She is not complaining of any shortness of breath, no chest pain, no palpitation. Now, this is the most important finding. At the end of the history, we ask a question, any family history of sudden death, especially related to heart. So that finding will be positive in here. So history of unknown heart disease in maternal uncle. So that will trigger you to think that this might be something like either it's a HOCM or it's a prolonged QT syndrome, because that is the two most common causes of sudden cardiac death in the family. In the physical examination, there is no murmur. So in HOCM, usually you get a murmur, so that will rule that out. And also you'll be given a ECG, which will show prolonged QT. Now you need to understand the prolonged QT and how to get it from the ECG. We normally don't discuss the full ECG in clinical course. We do discuss that in MCQ. What we can do is that we can add that class in your portal when you join the course, and you can go through our MCQ ECG class for a better general understanding. But for AMC clinical, you only need few ECG. If you know that, that's all that you require. Now, normal ECG looks like this. So obviously you know about all this PQRST. So normal ECG starts with a P wave, and then you have got a QRS complex, then you have got the ST wave. Now, this is P, this is QRS, this is T wave. There are two other important things that we should know. One is PR interval. So starting of the P wave and starting of the Q wave or R wave, that's PR interval. We know about the QRS complex, but for this case, we need to know the QT interval. So what is QT interval? It is a starting of the Q wave and finishing of the T wave. So this is the finishing of T wave. So that will give you the QT interval. And in case of prolonged QT syndrome, you will find out that QT is like really increased in squares. So how we normally find it out in a real ECG? We call prolonged QT syndrome when it is more than 440 millisecond in men and more than 460 millisecond in women. Most of the electronic ECG nowadays, they usually give you the QTC. So you don't need to even measure that. You can easily find it out on the top of the ECG. Okay? If you don't get it in the exam, then you need to measure it. So normal QT is 8 to 11 small square. If it is more than 11 small square, that's prolonged QT syndrome. And how to read a ECG, we will discuss that a little bit more in our next class, where we will be discussing the chest pain cluster and palpitation cluster. But today, whenever a ECG is given in your exam, it is always remember one thing, that look at the question, the history of the patient. The question will give you an idea that what are you looking for in that ECG. If a patient presenting to you with a chest pain, obviously you should look at V1 to V6. These are the chest lead. If a patient presenting to you with palpitation, you should look at the long lead, which is this lead 2 over here. So Depending on the presentation, you should look at certain important things so that you don't waste a lot of time just by looking at the ECG in the exam. Now, because it's a prolonged QT syndrome, if we look at, let's start with V1 to V6. In V1, we can see there is a T inversion. That's it, nothing else. The ST wave is also fine. We can see V2 is normal, V3 normal, V4, V5, V6, all normal, which means that it is unlikely to be a myocardial infarction. Then quickly check the other leads. So lead 1, normal, lead AVL, maybe a little bit of T inversion, but nothing significant. Then 2, 3 AVF. So lead 2, normal, 3, okay, AVF, normal. So nothing very prominent that you can get in the ECG. In that case, in your head already you know that there is a history of sudden cardiac death in the family. Looking at the question, you will have an idea that it could be a prolonged QT syndrome case. At that time, you look at the long lead, find out how much is the QT interval. So how to measure that? So you can see that this is Q, or let's say this is the Q, and that's the finishing of T wave, right? And then just measure how much small square is there. So this is 5 small square, this is 10, then you have got 11, 12, 13, 14, 15. So there is 15 small square in this QT interval. And we know that if it is more than 11 small square, that will be prolonged QT syndrome. So that's how you can come up with prolonged QT syndrome in this case. Okay? Always look in this way. In exam, I would definitely start with what I think this patient has got. And because in a real life scenario, you will have a lot of time to look at a ECG. But in exam, you don't have that time. So use that smartly. Given a patient is a 19-year-old, had a family history of sudden death, and also patient had a loss of consciousness, and there is no murmur, so it cannot be HOCM. So it most likely will be a prolonged QT syndrome, right? So then just check the QT interval. If QT interval is more than 11 small square, you got your diagnosis. Okay? How to explain an ECG to the examiner that comes in exam. So that will be discussed in our next class. So after you have done your history, physical examination, and ECG reading, your next task will be explain the diagnosis. So diagnosis in this case would be most likely from history, physical examination, and the ECG, you are having a condition called prolonged QT syndrome. Do you know what it is? No, doctor. Well, let me discuss in detail. So if you can see that we have done a electrocardiogram, in short, we call it ECG. This electrocardiogram is basically the recording of electrical activity of your heart. So you know that we have got our heart on the left side of the chest, and heart has got electrical activity to pump the blood. And this ECG that you can see has different parts which represents different components of this activity. So far, did we use any medical jargon? No. That's the important thing. You don't need to explain the ECG to the patient. Patient doesn't need to know what is P wave, what is QRS complex. They want to know what's happening to the patient, right? So in your case, the part that we call QT interval is markedly prolonged, and that is why we call it prolonged QT interval. This condition is commonly associated with abnormal heart rhythm, resulting in impaired pumping of blood, which causes frequent collapse, like in your case. Okay, so always try to correlate the patient's symptoms with the condition, because that's the thing that a patient wants to know, why I am getting collapse in a 19-year-old. Okay, so say that the part that we call QT interval is markedly prolonged in your case, and this is commonly associated with abnormal heart rhythm, which causes impaired pumping of blood, and because of that, your brain doesn't get enough blood supply, which causes this frequent collapse, like in your case. Sometimes this condition can run in the family. Sometimes it can be due to medication, can be due to dehydration or salt and water imbalance. It can be due to other causes as well. So you can give some of the differential diagnosis just like the other case and say why it is unlikely. And then if diagnosis and DD is the task, you will finish here. You don't need to talk about the management. But if management is a task, then you will say, unfortunately, these conditions sometimes can lead to serious consequences. That's why I need to admit you to the hospital. I will call my senior who will also come and review you. And most importantly, we will involve a heart specialist to review you. But please don't get scared. You are in a safe hand and you have done really good to come to us, and now we know what's causing this frequent collapse in your case. And with we have got a very good team of cardiologists who will be taking care of you. So reassurance is must in these cases. The specialist might do few investigations such as full blood count, kidney function, a blood sugar level, and also most importantly a echocardiogram of your heart. So you can explain this, that why we are doing an echocardiogram, why we are doing a urea electrolyte creatinine if you have some time. So basically full blood count to rule out any infection, urea electrolyte creatinine to rule out salt and mineral imbalance, blood sugar level mainly to rule out any hypoglycemia causing this, and the echocardiogram to rule out any structural abnormality of the heart. In terms of management, cardiologists might put you on a medication called beta blocker, which sometimes can help with reducing this abnormal heart rhythm that you are getting. And if it is still ongoing, if the medication doesn't help, then there are some other special cardiac devices that can be used, but that will be discussed by the specialist in detail in case it needed. So you don't need to talk about cardiac pacing and everything. Just say that if medication fails, then there are some special medical devices that can be used, but those will be discussed by your cardiologist in detail. Also, if all the investigations come normal and we can't find out any cause, then most likely you are having a congenital prolonged QT syndrome, which means it is running in your families. At that time, we would advise you to talk about this to your family members so that they can also screen that. Once you are discharged from the hospital, I will send a letter to your GP and he is going to follow you up. Jenny, I do understand that all of this information came as a shock to you. I do understand it is quite surprising, but I would like you to understand that if you have done a good job by coming here, and we can manage your condition. If you have any questions, feel free to ask us. We will try our best to make sure you understand everything. So always finish with something nice, and usually the examiner and role player will be very happy. Any question with this case? Now, do we need to tell differential diagnosis of prolonged QT interval or presenting complaint? Presenting complaint. Now, this kind of cases, prolonged QT syndrome, this is better to be done by the hospital team as early as possible because she is getting frequent collapse. And this is a condition which can lead to sudden cardiac death. So that should not be like on the waiting list to see a cardiologist. No, that's not also right, Dr. Javeria. So GP can organize a echocardiogram also in cases like aortic stenosis. If patient is stable, we would do a echocardiogram. Okay, so it can be done, and a GP can do almost everything, but they can't treat this patient. So that's the time a cardiologist will be involved. Okay? And you, as a junior doctor in the exam, it is always better to be a safe doctor rather than doing everything by yourself. If you say that you are going to treat everyone, that's the time usually candidates are failed. So you have to involve your senior every time. You have to involve the specialist every time. That's how they like you to do this case. Next task is postural hypotension. Postural hypotension also falls under syncope cluster, right? So a middle-aged woman comes with dizziness for the last several days. And there is another one is a 65 years old man comes to see you because he had a fall yesterday. Now fall, dizziness, syncope, these are all same cluster. And we will be using the same format as well. Just in case of vertigo or dizziness, we will just need to make sure that it is not vertigo, because if it is vertigo, then we need to add a little bit more differential diagnosis. But in other cases like fall, dizziness, lightheadedness, the same like syncope cluster. So how we are going to take a history for postural hypertension case? So you will find out in the history as a positive point that this patient feels dizzy when standing from a sitting or lying position. So that's the time you will know that this patient has got postural hypotension. Now, when you get a positive finding like this, you need to find out what's causing this postural drop. So there are lots of causes, but important ones are medication. So especially if patient says that they are on multiple antihypertensive drugs like diuretics, ACE inhibitor, ARB, maybe recently a dose has been increased, or maybe recently a new blood pressure lowering medication has been added. So something you will find out in the history that will lead you to understand that this is the cause of sudden drop of blood pressure. So most of the time it is related to diuretics like furosemide or thiazide diuretics that can cause it. Okay. And polypharmacy is always a problem in Australia. A lot of elderly patients are on a huge amount of medications, and medication interaction can cause postural hypertension in elderly patients. It's a very common situation in here. Okay, so look for any medication-induced postural drop as your first cause. If you don't find something there, then look for some others. So you can find out patient having diabetes. So in this case, patient had diabetic for many years, but it is well controlled. So how diabetes can cause postural drop? There is a condition called diabetic autoneuropathy. In diabetic autoneuropathy, patient can lose control of their sympathetic activity. Okay, and in that case, this can happen. Sometimes the findings that you can get in that case is that patient will have heartburn, reflux, they can have constipation, diarrhea, they can have sexual dysfunction. So some of the autoneuropathy feature will be positive in that case, which doesn't come in the exam anyway. And apart from that, sometimes infection. So any recent flu-like illness can cause postural drop. Any excessive vomiting, diarrhea can cause it. So those are the things that you will be asking in this case. Okay, so in the history, your main finding will be this. The only thing that you will add in your history is that did you have any recent flu-like illness? Did you have any vomiting or diarrhea lately? And find out any other medical conditions. If patient is diabetic, then ask all the diabetic question that how long you are diabetic, and are you taking any medication? Is it well controlled? What are the medications you are taking? So ask all the diabetic questions in that case and try to rule out any diabetic complications. So ask about any numbness, tingling in your feet for peripheral neuropathy, any problem in your urine output for nephropathy, any changes in your vision for retinopathy, and also ask about autoneuropathy, such as do you suffer from indigestion? Do you get bloated tummy a lot? Any change in your bowel habit, such as constipation, diarrhea? Any trouble with your sexual function? So all of these are autoneuropathic questions. You only ask it if you find it in your case. Okay? That will be the only thing that you will add in this case, otherwise everything is fine. When you come to the physical exam, you will find out that when you get the blood pressure, you will find out a postural drop. So let's say if a patient sitting blood pressure as 120/80, And when patient stand, blood pressure falls as 100/70. So if more than 20 millimeter systolic blood pressure drop or more than 10 millimeter diastolic blood pressure drop, when they change their position, that's postural hypotension. All right. So that will be the only finding that you might get in this case. So this is a typical scenario which comes in exam, which is a polypharmacy induced postural hypotension. There was another case like this one. Patient was taking risperidone for psychiatric problem. Now comes with history of dizziness. So this is also a postural hypotension. Risperidone is a notorious drug to cause postural drop. Okay, so that's also one of the cases that you can find out, and that you will find out when you ask about the medication history. You will find out patient is taking risperidone. That's one case. There is another one, which is patient was sitting in a church. While standing from sitting position, patient collapsed. Okay, that's also postural hypertension case. So you can get any kind of questions, but your main finding is when they change their position, they feel dizzy, and sometimes if it is really bad, they can even have a fall, and even loss of consciousness can happen. So the first case, how we are going to explain. So you will say most likely from history and examination, you are having a condition called postural hypertension. Do you know what it is? No, doctor. Well, this is a condition in which there is sudden drop of your blood pressure when you change your position from lying or sitting to a standing position. It could be due to many reasons such as severe vomiting, diarrhea, high fever, strenuous exercise, but in your case, most likely it is due to the multiple medications you have been taking. And if you have got any other finding, like you have recently increased the dose of one of the blood pressure medication, and I think that might be the cause of your sudden blood pressure drop. Or if you find a new medication has been introduced, you can also explain that. Also, as you are diabetic, it could be due to another condition called diabetic autoneuropathy, which manifests as heartburn, bloating, diarrhea, constipation, difficulty with bowel and bladder, and sexual dysfunction. But your blood sugar seems to be well controlled, so it is less likely. This type of dizziness or fall can be due to other reasons such as heart rhythm disturbance, structural heart disease, heart attack, stroke, seizure or epilepsy, head injury, salt and mineral imbalance. Sometimes it could be a vasovagal syncope, etc. Now, this is just a differential diagnosis, what is written in the note, but ideally you will explain why it is unlikely in this patient case. So you will say that it could be due to other causes such as heart rhythm disturbance, but you don't suffer from any palpitation, so it is unlikely. It could be a heart attack, but you don't have any chest pain, any sweating, nausea. That's unlikely as well. It could be a stroke, but you don't get weakness or any problem with your vision or speech, so it is unlikely. Could be seizure or epilepsy, but you did not have any jerky movements during these episodes, so it is unlikely as well. That's why I would like to do some investigations just to be sure that we are not missing any other things. So we'll do basic bloods, including full blood count, to rule out any infection, inflammatory marker, urea electrolyte creatinine to check for any salt and mineral imbalance, to check your kidney function, liver function, and your blood sugar level. We will also do a ECG just to be sure it's not related to any heart problem. And if everything is normal, then we know that it is most likely due to the medication change. In that case, we will consult with your cardiologist who has recently added a new medication to see that if he is happy for us to change or reduce this medication. Okay? And then you can just explain some other thing that what we can do to make sure patient doesn't get a fall when they're changing position. So there are some basic management. So you can say this line, meanwhile, I would like to be aware of general rules to be followed when when you are suffering from a postural hypertension. Okay? So you can say that take all your medication as prescribed. have a same routine to take them, like have a routine to take at the same time every day so that you don't miss a dose or increase a dose. If you forget to take a dose, take it within the next few hours, otherwise skip the dose. Please do not double the dose. Okay, never. And if you have any side effects, then stop the medication and talk to your doctor. You can follow a half-minute rule. So this is the main thing I was going to say. So when you get up in the morning, sit up slowly and stay there for 30 seconds. Then put the legs over the side of the bed for 30 seconds and then slowly get up and walk to prevent any sudden drop of blood pressure. So this 30-second rule is very good. So you can also ask the patient to follow this. All right. And lastly, say that you would like to see the patient after all the blood tests are back. You will give some reading materials and you will wait for the specialist to contact you to change the medication. Okay. Any question, guys? And we have also written what we have to do for risperidone induced postural hypotension. So you can say in here that you have a condition called postural hypertension, discuss what is that, and say that in your case it is most likely that you are getting a side effect of risperidone, or you might have taken a higher than normal dose that was prescribed. It's quite commonly seen within the first week of treatment, even at a normal dose. Sometimes patient can ask, when you say that it is side effect, patient can say, well, so did you do a mistake? Or did my doctor do a mistake by starting this medication? How you are going to answer such a case is very important. This is kind of tricky, confusing trap. So you should always say that, well, your doctor has prescribed what is best for you. I would prefer to take a look at the prescription, and if possible, I will talk with your wife who takes care of your medication. So you will not say that, yes, the other doctor has made a mistake unless you are sure about it. So you will say your doctor most likely has done what is best for you. As I said, that sometimes even you can get this side effect with a normal dose. But before we say anything, I would like to have a look at your prescription. And if possible, I would like to talk with your wife who takes care of your medication. And as part of the management, we need to keep you in the emergency department to observe your blood pressure and to do some basic blood tests. So full blood count, urea electrolyte, blood sugar level, and a risperidone blood level. I will also call the psychiatric team to review your condition. They might adjust the dose of your current medication, or they might decide to switch it to another one. If they decide to change, then you will need to stay in the hospital for the crossover period, which takes around 2 weeks. And meanwhile, I would like you to be aware about some of the general rules. So then you will discuss the general rules and finish the task. Okay? So that's risperidone-induced postural hypertension. Any question about these, guys? Are you understanding that you are using the same syncope cluster for all of these cases that we have discussed so far? Okay, moving on to vasovagal syncope. 18-year-old girl fainted during marathon running during the annual sports, now fully recovered. Mother came to consult you. Take history, physical exam, tell possible causes. This is a very important case, and always remember in exam, it's not always that you will get a single diagnosis. You can get multiple diagnoses in a same patient. So always look for some others and don't stop if you just get one diagnosis. Sometimes they have 4 diagnoses in a case. So 18-year-old girl fainted during marathon running. Remember I told you that vasovagal syncope is usually associated with some strenuous exercise, and most of the time it will be marathon running or annual sports running. Now, in this case, girl fainted during running. It was a hot sunny day. she also skipped her breakfast. So that's one other thing. She skipped the breakfast and then went to marathon running. Okay? And you have found that patient's blood sugar is 3.6. So if blood sugar is less than 4 millimole per liter, that's hypoglycemia. So this patient also having hypoglycemia, and that's because of this skipping the breakfast and then going to running. So physical examination will be totally normal. So you will say that. Now, one other thing I forgot to explain is that 18-year-old girl, many times they get iron deficiency anemia. What can be the cause of iron deficiency anemia in an 18-year-old? What do you think? The common one, Dr. Mariam. Heavy periods, Dr. Jahra, very good, very good. Yes, most of the time it is either eating disorder, but most commonly it is menorrhagia. So you should always find this out, especially in this age group. Menorrhagia, heavy bleeding is very common. So you should ask that first question. You should add in these cases that, do you feel tired and fatigued these days? That was the anemia question in your format. If patient by any chance say yes, then you will ask a little bit about how is your diet? Do you take healthy balanced diet? Ask about eating disorder, like do you starve yourself or do heavy exercise to lose body weight? That's one question you can ask. Most importantly, ask about that I'm going to ask about your period. Is that okay with you? So take a permission and then say, when was your last menstrual period? Because syncope in an 18-year-old, if she is sexually active, it can be even a pregnancy. We don't know. Could be ectopic pregnancy. We never know. So ask about their last menstrual period. Okay. And then if it is, let's say, 2 weeks ago, then say that, is it regular? Yes. So regular 2 weeks ago, ask, are you sexually active? Yes, doctor. Is there any chance you can be pregnant? No, I use contraception. Okay. So how is your period? Do you get heavy bleeding during your period? Yes, doctor. Okay. So when you get heavy bleeding during period, that can be the cause of anemia in this age group. So that can be one of the other finding in this case. Remember, I told you that you can get 3 or 4 diagnoses. This case has patient having vasovagal syncope, hypoglycemia, and a iron deficiency anemia. 3 things. So you have to find all of these in this case. Okay? And try to add this period related questions in every female who is presenting to you with syncope, because you want to make sure they are not pregnant. You want to make sure they are not having any iron deficiency from heavy bleeding. Okay? So how you're going to explain this vasovagal syncope to the mother? So you can say the temporary loss of consciousness that your daughter experienced today is what we call as syncope. There are many reasons which can cause it, but in your daughter case, there are 2 possibilities that I am thinking right now. One is called vasovagal syncope. In this condition, in response to certain triggers, such as overexerting in hot sunny weather, it can stimulate a nerve in our body, which causes pooling of blood in our legs. Because of pooling of blood in the legs, there is decreased supply of blood towards the heart. And if heart doesn't get enough blood, it can't pump blood to her brain. And that caused the temporary faintness or collapse in your child case. Please don't get scared about it. It is a very common cause of fainting, and there is nothing to worry about. The other condition that can precipitate this attack is hypoglycemia or low blood sugar. Because your daughter skipped the breakfast today and then went for a marathon running, that can also lead to low blood sugar, because we also measured her blood sugar, which we found as low. So we have already. Now, one of the other thing, if by any chance in the physical examination card you found patient BSL 3.6, after you have finished reading this, you have to immediately say, dear examiner, I'm going to arrange a glucose drink for this patient, because her blood sugar is very low. So that's a must to say, because this child or this 18-year-old is having a hypoglycemia in front of you, and it can drop down and patient can went into another unconsciousness. So once you finish your card reading, immediately say, dear examiner, I would like to arrange a glucose drink for this patient because her blood sugar seems to be low. And that will cover it. And at the management, you will just say that we have measured your daughter blood sugar, which is low, and we have already given some glucose drink for her, and we are going to recheck the blood sugar to see if it is up. And then just give some other differential diagnosis as well. Okay, clear everyone? But if you get that iron deficiency problem in this case, then you have to arrange some investigation. So the main investigation is full blood count, looking for anemia, and also a iron status, and also a coagulation profile to find out if the patient having any, like, why the patient having heavy bleeding. All right, so that was vasovagal syncope, which is super important for exam. The next task is a recurrent fall in elderly. A recurrent fall in elderly is one of the most commonly asked questions from syncope cluster. I can't say enough that how important this case can be. And AMC changes this case a lot. Okay, but the theme is same, recurrent fall. So differential diagnosis of recurrent fall, polypharmacy is the most common cause. It could be postural hypotension, could be medication induced heavy bleeding, diarrhea, vomiting, or fever. Vasovagal syncope, CNS CVS cause, could be endocrine as diabetes, can be hypoglycemia, can be retinopathy or neuropathy. Electrolyte abnormality due to vomiting, diarrhea. Anemia could be abnormal home situation. So in any recurrent fall patient, we need to know that how is the home situation of this patient? Is there any poor lighting? And that's why patient having a fall. Is there is lack of railing on the stair? How about loose carpets? So we should find out the home situation, vision and hearing, and any joint problem. Like patient who is having a lot of osteoarthritis, they already have poor gait and poor ambulance, right? So when a patient has poor gait and poor movement, they can easily fall as well. So find those inherent issues in a patient, and that's all that we need for this case. So if you see that this is also more or less the syncope cluster, only few of the new differential diagnosis has been added. So first of all, your history will start with the same introduction and then find out about the fall. So how many episodes you have got so far, and find out each and everything about all the episodes that happened over the last few months. And then about the recent fall, ask what happened before the fall, during the fall, and after the fall. It's the same pre-syncope, syncope, and post-syncope question. Then come to the differential diagnosis. So CVS questions as like before. CNS question, ask about CNS related like headache, blurring of vision, weakness, everything. Then come to the postural hypotension question. So do you feel dizzy when you change your position, especially when you get up in the morning? If yes, then ask any fever, any recent vomiting, diarrhea, any bleeding from anywhere. For anemia, do you feel tired and fatigued these days? And how's your diet? Is it healthy, balanced diet? Ask about past medical history. How is your general health? Any history of high blood sugar, stroke, high blood pressure, and any heart condition? In many cases with recurrent fall, you get diabetes positive in the patient. So if diabetes is positive, you need to ask each and everything about diabetes. So how long you are having this? Is it well controlled? Okay. You can say, are you regular with your specialist? Any medication you are taking? If yes, what medication are you taking? And who takes care of your medication? Any problem with your vision, so that's for retinopathy, any numbness, tingling sensation in your lower legs. Okay, many times this case you will find out patient having vision problem, patient having neuropathy, and also sometimes you can get that patient's diabetes is not well controlled. Okay, so this past medical history is very important to find out. And lastly, finish with medication history. Ask detail about all the medications patient is taking, any recent change in the dose, any new addition of any medication. Ask about the home situation. So who do you live with at home? Any loose carpet? Any poor lighting at your home? Do you have any joint problem? Any problem with walking or keeping balance? Ask about smoking, drink alcohol, and ask about do you have enough support? Support is very important because if patient lives alone at home and they are having recurrent fall, that's a high risk situation. Okay, so you'll need to find out if there is anyone who is supporting the patient or not. So this is a recurrent fall history. So you'll follow the same format, but we are just adding few things as relevant to this case. Physical examination in this case, because you have found diabetes positive, so you will obviously add some diabetic related examination. So general appearance, vitals and BMI, pickled as relevant. We also check the eye because patient has vision problem. So we check for visual acuity, visual field. We do the fundoscopy. We will do the full CVS and CNS exam, including looking for any diabetic peripheral neuropathy. We will do a musculoskeletal exam because patient has got joint pain. And obviously in the office test, we'll be looking for blood sugar level and urine dipstick. Okay. Now, this might be a little bit complex for you because we haven't done any physical examination so far. So just keep this in your head that this is what we do. But when we do the physical examination classes, it will become much easier for you. Okay. The positive point in this case is that this patient has got 3 episodes of fall recently. Is diabetic for 10 years. Is getting numbness, tingling on the lower legs and vision problem. Knee pain. Past history of stroke, taking physio now. On the physical exam, you found fundoscopic feature of retinopathy, peripheral neuropathy positive, and blood sugar is 16, which is very high. What is the normal? If it is random blood sugar, up to 11.1 is normal, but this is 16, which is very high. So you understand in this case that this patient is getting recurrent fall, most likely due to poorly controlled diabetes causing retinopathy and peripheral neuropathy. So you can say most likely the cause of your recurrent fall is uncontrolled blood sugar causing some complication. First is causing peripheral neuropathy. In that condition, the nerve that supply your lower leg gets affected, causing numbness and tingling. And that's why sometimes you might not even know where you are stepping and you can easily have a fall. Also, we have found some eye changes related to diabetes, which is affecting your vision called diabetic retinopathy. On the top of that, you are having knee joint problem, which can lead to recurrent fall as well. Are you with me so far? Now, then give some differential diagnosis. Management usually doesn't come in exam, but if it comes, you have to explain what you're going to do for this patient. So ideally in elderly patient recurrent fall, you would first, you can arrange some investigation, so baseline blood test, and then what you are going to do is called, you are going to arrange a recurrent fall team. Okay, this recurrent fall team is made up of multiple allied health professional, and that multiple allied health professional can be a social worker, can be a physiotherapist, can be an occupational therapist, can be a geriatrician, it can be a counselor if patient is stressed about lack of support. Okay, so this is the main allied health team who will work with the patient, and also a community nurse. So you can say that a social, so we are going to involve a recurrent fall team for your further management, In the meantime, we will do some basic blood test. The recurrent fall team will involve a social worker who can come and help you in the house to do all the activities. So if you need to go shopping, they can help you. If you need help with cooking, they can do that for you. A physiotherapist also can be involved because you are having knee problem, you had a recent stroke, and they can also help with some muscle strengthening exercise. Occupational therapist will come into your home and they will assess your home situation for any loose carpet, any trouble with your stair railings, and also they can they can look for any poor lighting or any other abnormal finding in your home, and then they will correct it accordingly. A geriatrician is a specialist in for elderly patients, so they can also look for any other physical causes of fall that you are having. And if you're feeling stressed about this, if you think that it is causing depression or you are having a low mood, we can always involve a counselor as well. As you are having a lack of social support, you don't have anyone to take care of you. If you want, we can also involve a aged care assessment team to see that if you fulfill any of the criteria to get help from some of the other allied health professionals. Okay, so this is usually the management for recurrent fall that you can do for this patient. The other thing is that you'll obviously need to find out what is the HbA1c of this patient, because this patient is having poorly controlled diabetes. You need to involve a diabetic specialist like an endocrinologist who can look at the medication and change it accordingly. That's must in this case. And if it is diabetes related, the other thing you can do for this patient is you can involve a podiatrist who can help with some of the food care, because this patient having a peripheral neuropathy, so a podiatry will be a good idea to add. Okay. Any question, guys? So that's all about today's class. Vasovagal syncope, do we say avoid triggers? Yes, you can say, like you can always advise the patient it is best to avoid hot sunny weather and running in this way because it can again happen. Ideally, if your only task is give diagnosis and DD, then better to give reason why your differential diagnosis is not your diagnosis. All right, so let's finish our class tonight. We will start with two other cluster in the next session, which is palpitation and chest pain, which are also super important for your exam. Now, the thing that I wanted you to understand that how we use one cluster to cover multiple cases, and you can see that throughout these classes, you did not need to know about the history, you did not need to know about the physical exam. All you needed to remember is the management, which is easier, right? So that's how we take our theory classes, and in that way, the exam preparation becomes very solid. We always say it's better to prepare smartly rather than doing everything and not able to perform appropriately in the exam. All right, so we'll finish it here tonight then. Now, do you guys have any questions about the course or about the classes, anything that you want to know? All good then. So you already know where to look for our course details. If any of you are here who want to join the course, but still you are just doing the free 2 week session, I would say start the process because it takes a little bit more time at the moment because everyone is admitting into the course and our team is already overstressed for that. So if you are planning to join the course, I would say please make sure you join it as early as possible. Yes, Dr. Jamshina. So you use the same history for all cases that come under one cluster. Sometimes we change a little bit based on what we get, but mostly it is same. And Dr. Sayada, so if you have made an account in our software, then in the software, once you get the access, all the class notes and recordings will be there. Okay. All right, everyone, we'll finish it here tonight and join our next class again. And we can finish what we have started, which is the cardiology. You will also get another random role play session with Dr. Cynthia. And hopefully, we should be finishing with your 2-week session, and then we will start our course in full rhythm. Do we need to make our own notes? No need, because we are providing you everything. So you don't need to make your own notes during the session. All right. So thank you all. Have a good night. Let's finish it here tonight. Bye. Take care.